Okay, so we're going to talk about mobility and immobility, and this lecture is going to be heavily focused on the effects of immobility on body systems, and we're going to talk about potential complications. When we're talking about another thing we need to think about in mobility, in regard to mobility, is using assistive devices. There are some really good videos that I've posted for you with physical therapists teaching how to use assistive devices. So first of all, what are the effects of immobility on different body systems? The integumentary system. Immobility increases pressure on specific areas or on a few areas of the skin and subcutaneous tissue. If I'm up walking around, then the areas of my skin and tissues that are being compressed against a surface or between a surface and a bony prominence change. I'm up moving when I'm sitting, maybe it's sacrum or hips. When I'm lying down, it would be shoulder, hips. But when I move around through the day, I'm changing that pressure all the time. If someone is unable to change positions or unable to change positions frequently, they have the same tissues that are being compressed between a bony prominence and a surface a lot of the time. There are also some metabolic changes with immobility that actually worsen that effect. So patients who can't move are at risk for skin breakdown. The respiratory system, when we are moving around, we're taking deeper breaths. Exercise requires more of our oxygen capacity, of our lung capacity. So we expand our lungs fully when we move around. When we're sitting, when we're lying, we don't tend to expand our lungs as fully. And lying actually can constrict or decrease the amount of lung capacity that we have for a given breath. So when we don't take deep breaths and expand all of our lung tissue fully, the alveoli that are at the perimeter of the lungs start to collapse. It's called atelectasis, and they collapse down. And maybe if you take a good deep breath, you'll hear crackling when you auscultate because they pop back open, but they're not staying open because that patient is not consistently opening them with deep breaths. So what happens when we have alveoli that are not staying consistently open is the mucus that's produced to trap debris and move it out of the lung tissue actually starts to sit. We have secretion stasis in those alveoli. Whenever we have secretion sitting in one place when they should be moving, there's a risk of infection because those are a great place to grow bugs. The cardiovascular system, we actually have less blood volume in the circulatory system with decreased mobility, partly because we're taking in less. If it's hard to get to fluid, we're taking in less, but also because when it's sitting, if we're not circulating effectively, that blood will start to move out into body tissues and we have some edema. We also have venous stasis. Walking, moving around promotes venous return. The arteries pump blood forward actively. Venous return is passive. So blood is moved up and then a valve closes to trap it and prevent it from backflowing. So when we're not moving around to encourage that blood to move up, it tends to stay in the same, it tends to collect in those veins. They start to stretch out some. When we have venous stasis, anytime blood sits still, it can clot. We also, with long-term immobility, have decreased autonomic response. Part of the autonomic nervous system is when we stand, we vasoconstrict the lower extremities in order to maintain blood in the head and vital organs. Without that vasoconstriction, all of our blood goes to our feet. We have syncope. So with long-term immobility, patients become less able to tolerate being upright because when we move them upright, they don't vasoconstrict to maintain the blood where it needs to be. We also have decreased cardiac output with immobility because we have more blood that's staying in the vascular system or in the veins and not moving back toward the heart. And we have increased oxygen requirement because we're not really meeting our oxygen requirement very well. Metabolic, we have a decreased basal metabolic rate, which means we burn less energy when we're not moving. That means that people will tend to gain weight if they're not able to move. There also are changes in the way the macronutrients are metabolized. People in immobility frequently are in a negative nitrogen balance. They begin breaking down muscle tissue that's not being used. It atrophies. So they lose muscle mass. They can be in a negative nitrogen balance. They may lose weight. We may have weight gain because they're not burning calories, but also they may lose weight because of that muscle atrophy. And that's going to depend partly on intake and are there other things that's taking that energy. Bones need weight bearing to hold on to calcium. So when we're not bearing weight on those big weight bearing bones, the calcium starts to be reabsorbed into the bloodstream. And the kidneys don't eliminate that calcium as effectively. So that can actually lead to kidney stones. Elimination, the bladder, we have urinary stasis. Urine will sit in the kidneys and the ureters longer and in the bladder longer, which becomes a site for infection. We often have hypercalcemia with immobility because of the blood being leached, or not the blood, because of the calcium being leached out of the bones into the bloodstream because we're not bearing weight on those bones. A lot of people, when they're not mobile, have decreased fluid intake. They're more likely to have an indwelling catheter, and sometimes that's for legitimate reasons, but sometimes that's for reasons of convenience to us, but that increases the risk of infection. And there's decreased peristalsis in the ureters. There's also decreased gastrointestinal peristalsis, which means we are more prone to constipation. Musculoskeletal system, the muscle tissue is broken down when we're not using it. So we have muscle atrophy, which causes loss of muscle mass. We also can have, if we're not moving joints, they can lose range of motion, and we can have patients with contractures. Neurologic and psychologic. If we're not getting enough sensory stimulus, we can have altered sensory perception. So your brain needs something to do. Sensory stimuli come from vision, hearing, taste, smell, touch. If you're immobile, you're more likely to have limited sensory input. So if we're not getting enough sensory input, our brains make up stuff to fill in the gaps. Your brain needs something to do, and it will make it up if you don't have enough sensory input. So that leads to altered sensory perception. Things may sound louder or look brighter, or we may actually begin, like I said, our brain can actually make up sensory input, and we have hallucinations. Decreased mobility also can lead to depression, anxiety, and altered self-concept, because a lot of our self-concept is based on what we're able to do. There are developmental effects. Children who have decreased mobility may begin to miss developmental milestones. And if a child has a permanent impairment of mobility, say the child is paraplegic, not only are they missing milestones like walking, because clearly they're not going to be able to walk, but not being able to move affects their ability to meet other milestones because they're not necessarily getting the stimuli or the opportunities that they would. So one of the things that we need to do with children who have mobility issues is to make sure they have ways to get their other developmental needs met. So it's common for kids with mobility issues not only to have delayed motor development, but also delays in other types of development. In adolescents with mobility alterations, their growth spurt may actually be altered. It can Immobility or mobility impairment can decrease the development or slow down the development of independence. Sometimes that's because there are some logistical issues, but sometimes that's also because parents are afraid of that independence. And it can lead to social isolation. In adults, loss of mobility causes a change in roles. Adults often feel that they should be the caregiver, and if they need care, that affects their role development. And it can have career and financial impact, and an impact on the family. In elders, once mobility is lost, it is very difficult to regain. So it's common for elders to be admitted to the hospital for, say, pneumonia, and leave with worse function overall than they came in with, because they have pneumonia, they're in bed, they may be gotten out of bed a couple of times a day for meals, but depending on staffing, maybe not. And once they stop getting up and moving around for a few days or a few weeks, it's often really hard for them to regain that lost mobility. Okay, in the next section, we're going to talk about assessing mobility and the complications of immobility.